to get this group together and be focusing on these kinds of things. So I'm at Exeter now. Present some work from the World Bank where I was, and I'm still affiliated. It's the Mind, Behavior, and Development unit there, so it's very similar. Like, all the acronyms I think are overlapping a lot, but trying to do similar kinds of things. I only have 20 minutes, so it's hard to go through a full paper, so I figured instead I'd go through 4 papers and give you some big picture things, because we're getting toward the end of the day, so we'll see how that goes. But those will be very brief. I did shorten the title from what's written, so we've saved some time already. Okay, so I don't have to motivate any of this here, but just to put it out there with this audience. So 2006, the latest numbers, hopefully we'll get something more soon. Latest, I think, that I've seen from WHO. The global burden of disease, as measured in DALYs, disability-adjusted life years, 6.4% was due to mental health, and that includes substance abuse as well. That's up from 5% in 2000. Obviously, percentages are zero-sum, so it's got to go up and down, but it's just to say it's increasing in importance overall. This is also very likely an underestimate, given what we know about reporting and stigma and biases around mental health. So again, hugely important. And just on this agenda, I have to mention, so both my father and my aunt have been very active in this, and so it's really inspired me, so it's great to see it come together. My father, Dean Jamison, is a health economist and was one of the originators of DALYs on the global burden of disease work, the World Bank, WHO, and others, and with Gates Foundation. My aunt, Kay Jamison, is a clinical psychologist and has worked a lot in this area as well. She's a professor of psychiatry at Johns Hopkins, so mixing the psychology and psychiatry. And I'm sort of, I don't know, thinking of myself somewhere more than this, but a little bit bridging the gap between sort of aggregate work, the kinds of things my father does on cost effectiveness and health systems, and then this a little bit more individual behavioral science, psychological approach that obviously a lot of behavioral economists are doing. And I'm also pointing out, so the first paper, I won't say anything about it, but just my second publication there is on economic effects of lithium early on, published in Psychiatric Quarterly almost 20 years ago. So I've been thinking about this for a while in one way or another. Okay, so that was the wide angle. Too quickly on a couple of other studies, and so we'll see. I'm optimistic on time, but we'll see how it goes. I don't think it's going to take too long. So first, Nigeria. So this was a project with the World Bank. They were doing a representative household survey in Nigeria. I don't know if I have the dates here, but this is like 2015-16, so a few years ago. So representative survey, which is nice to get, not that easy to do. And we added, so that's already happening, we added depression scale and some questions about adverse events or shocks. I won't say too much about, but I think this is Nigeria, so there's a lot of violent conflict going on around that time, Boko Haram and others, and then the usual kinds of things. So for the paper, which is a working paper, it's not published, we roughly categorize into exposure to violent conflict, and then sort of communal shocks, such as droughts and other things, and think of like price shocks there as well, and then something like individual shocks, like family deaths. So first of all, we find 22% of the respondents are depressed. It's a score of 10 or more to 30 on the CDSD-10. Nigeria has a population of about 200 million, so you can multiply that out, and see how many depressed people you get. This is a big number. Not surprisingly, significantly associated with poverty in general. And in this case, we found, and it was interesting to hear some of the earlier work, not as strong a relationship, it's still a little bit higher than 22%, but not too much for something like death in the family or for the communal shocks, so that fits a little bit with what we heard before. And is there some sort of sense of agency and individual connection? We do find a much higher rate for violent conflict, exposure to violent conflict, so that isn't necessarily something that they've done, but maybe they feel a little bit more responsible if they're even nearby. And then in terms of economic outcomes, a little more downstream, this is all correlational, associational. There's no experiment, there's no causality here. I should say that up front. The depression, we find a link between depression and reduced labor market participation for both men and women, and reduced educational investment in children. We even see slightly higher rates of child labor in households where the head of household is depressed, or the respondent is depressed. Those my focus on that. Okay, so second, this mentioned a couple times already, which is nice. So this study, this CBT study we did in Liberia some years ago. So this was Chris Blattman and Margaret Sheridan, who's a developmental psychologist. Chris is also an economist. So basically, we had 1,000 marginalized, at-risk young men in an urban setting in Monrovia, in the capital. We cross-randomized between CBT that we developed with a local NGO and especially with Margaret's input as well, an unconditional cash grant. So this is similar back to what we heard about for this morning with Johannes and others. We find in the short run, so think roughly 1 month, a few weeks to a month later, all 3 arms relative to control, so the CBT only, cash only, and combined CBT plus cash, all 3 arms improve economic outcomes, that's pretty obvious for the cash, less obvious for the CBT only, and improve antisocial behaviors. Let's just set it up for the most part into 2 indices as our primary outcomes for economic outcomes, antisocial behavior. We do look at pathways and mechanisms. So we see some on-time preferences, which is what I was actually most interested in this. We're trying to think about, again, relates back a little bit to some of the work earlier. Are these malleable a bit? Can we change in adults, in young adults, but not in children? Can we change their preferences, their discount rates and time preferences? It looks like, according to some measures, we can. That might be one of the things that's leading to better outcomes. Also personal identity, which is a lot of what we were focused on. We have a model of that. And then also self-regard, self-esteem, and mental health outcomes. So it looks like multiple possible mechanisms there. So that's all great, but then in what we called the long run in that paper, which was 1 year, which was relatively long run, everything goes away except the psychological outcomes, the antisocial behavior in the combination arm. So nothing in any arm on economic outcomes, it's all reverted to the same as the control. Things have kind of fallen apart. And it seems like this combination, there was an interaction there that we interpret that with some qualitative data as you've got the cognitive behavioral therapy intervention along with a chance of sort of practicing it. So we think of the cash as this is a constrained group. They're not the poorest of the poor, but they're quite poor. So the cash gives them a chance to kind of practice these behaviors that seem to be better. And so the 2 together with the practice, then that lasts for 1 year. So that was exciting to see, although not perfect. So as you can see there, we got funding last year to go back and try to find these guys 8 years later. See what happens with that. I don't have those results yet, obviously. We did, to Frank's last point last talk, we did try to find a few of them first, to convince the funders whether this was even going to be remotely possible. It was hard enough after 1 year. We spent a lot of time trying to find them after a year because these are no permanent address. These are like petty criminals, basically, on the streets of Monrovia. They changed their name, they changed their phone numbers. We went through their moms, that was the best thing. We got through their mom's cell phone number. We had to call up the mom and say, these guys are okay. If they get in touch, it's all right, you can tell them where to find me. So that's what worked. 8 years later, we're going to see. But we found some of them. We did look for it. We found some. We got some funding. We'll see what happens with that. Okay. So here's this particular one in Pakistan where we have very preliminary results as well, and some more to come. So this is entrepreneurs of SMEs, so small and medium enterprises. That means roughly 50 or fewer employees. So there's quite a range there, but on the smaller side, but this is not self-employed. These are actual entrepreneurs. So the thought was, and we did actually quite a long literature review, which we tried to put together separately as a working paper, that if you're an entrepreneur, there's already a lot going on. There's a lot of uncertainty. So you have, it's just a riskier thing. That's the whole point, in some sense, of being an entrepreneur. One of the defining characteristics is it's much riskier than other approaches. So you have this financial uncertainty, which is not so much fun to deal with, probably not good for your mental health. You have maybe someone on report saying they don't really know, they're sort of forced into entrepreneurship. In a lot of these settings, we hear this come up a lot in developing countries where there isn't a lot of wage labor or salaried labor. So you could be a subsistence farmer. If you're in a rural setting, you can be an entrepreneur, but it's not that you've had some great idea and you're going to go patent it and go out there. It's maybe you're sort of forced into it. So they feel like you don't have the skills necessarily that they need or want. There's issues around work-life balance. Because you're spending a lot of time, you're really quite responsible for this, you're responsible for your employees if you're in charge. So that's already there, so it's already a hard business to be in. And oh yes, so one point I should say, similar to the Liberia project and similar to some other ones we talked about, this is, the intervention, these are sort of high stress environments, but not necessarily clinical. In fact, for the most part, maybe not passing some clinical threshold for depression or anxiety. Exacerbated in FCV settings, so fragility, conflict, and violence settings. Here we're going to be in northwest Pakistan, near the Afghanistan border. So a lot of conflict, a lot of, unfortunately, fairly high percentage of the population in the world lives in settings that are post-conflict or conflict affected or recently conflict affected. So this is not a small proportion of the population. So it's only going to make things worse. So that was sort of our targeting is here. I'll say a little bit more, not too much, but about the background and the context, but the idea entrepreneurs may face some of these issues, particularly in some settings that are quite common. So what can we do about that? Can we do some version? And this sort of came out of the Liberia study in the sense that there was this idea, there was a World Bank project in the background. The Liberia one wasn't World Bank, but this one is Bank again. So they have a project going on with the entrepreneurs, and they're coming around to the idea that not just financial help, but non-financial support of various types can be necessary. And so they said, oh, well, CBT seemed to work for some things in Liberia. And so in this sort of universalist economist approach to things, oh, let's do that here, let's do that there. CBT, let's do that. That's going to help. So we want to see, all right, is there a version of that which we can do something with? And then what are the downstream sort of economic consequences? And so this is joined with a particular Atif Rahman, whose name came up before as a psychiatrist, and Usman, who works with him, and a couple of my colleagues at the World Bank. Okay, so a little bit more on the context. So this is the two areas. So we'll talk about like KP Fatah, two areas in northwest Pakistan, especially high exposure to conflict. Fairly small sample size. That was what we could come up with, but I'll say that up front. So this is sort of, I'm not going to say proof of concept, but this is not going to be as robust a study of results. So it's just sort of see what we could do. So that's our sample size. It's like 95% male. It's not our choice, it was there. We were really hoping to try to recruit a few more female entrepreneurs and see if there are differences there, group them together, but that's what it was. Working in a variety of sectors, manufacturing is the largest, I think it's about 1/3 of manufacturing, but a number of different sectors. So not specialized on that front. The income for the household, the median household size is 10. So this is poor in the grand scheme of things, but not extremely poor. And as I said, the size of the businesses are, they have a few employees each, and some of them in a larger size have a couple of dozen employees. So this is not super small or limited, but they've got large households, large numbers of dependents, I should say. So the World Bank program in the background is giving these cash grants. So this is quite large. But again, these are medium-sized businesses. It's specifically to rehabilitate the business. This is not an unconditional cash grant. This is not going to the household. This has to be used for the business. So, and we're not randomizing that. We asked. They said no. So anyway, we didn't randomize. So we're not doing any evaluation of that. What we're doing is on top of that. So within a group of firms and entrepreneurs who are leading the firms, who've got this cash grant coming, we're going to randomize whether or not we get this psychological intervention, B1. Okay, so it's based on problem management. We've heard about this morning from Johannes, which is, again, as an outsider to this, but I think my understanding, similar, has something I'll say a little bit about the curriculum, but similar to a version of CBT. This was, the WHO had used this, had an Urdu version. It had been tested in clinical populations in KPK and parts of this in this area of Pakistan. So it's already been used there for its sort of intended purpose in some sense. I know we're going to adapt that slightly for this group. So we do adapt it for this entrepreneurial population. We call it PM+E. And so one of the things we were worried about is, are they going to, if we say, not that we would have quite done this, but we say, oh, here's a mental health program for people who have mental health problems, do you want to come and sign up? We're not going to get a lot of people probably signing up. So we sort of describe it, we frame it, we advertise it, market it in terms of adaptive skills, leadership, self-improvement, which I think is all fair enough, but to make it sort of for this particular population. So part of it is that, part of it is the framing for the entrepreneurs. And then part of it is the examples we use basically in the curriculum. take-up rate is 64%, a little lower than we'd hoped. That varies, of course, well, not surprisingly, by the sort of the size of the business. So people have a more successful business, have a higher opportunity cost of their time, and are less likely to come to this. So the take-up refers to, so it's 5 sessions, once per week over 5 weeks. So if they come to 3 or more sessions, then we say successful take-up. All of the analysis is going to be intent to treat, regardless of that. So it's a little more, so it's 3 hours a week, so it's like a weekend afternoon or morning they get together. I should say also it's group-based, so it's different than some of the one-on-one ones. That's similar to Liberia. Also, as in Liberia and some of the other things we've talked about and can maybe get into a discussion, it's not professional. You know, there's a sort of professional psychologist who's run this, but then they train the trainers, and the people actually delivering it are not, you know, professional therapists in any sense. So they're meeting once per week. We also had, to the technology discussion, partly because it was group-based, we have a WhatsApp group. So we set up the WhatsApp groups between them. We tried to have people in similar businesses, similar sectors together. Did it also by gender, although I didn't mean too much here. So these are the curriculum, roughly speaking, the 5 sessions over once per week. This is going to look very standard given what we've seen today already. Okay. The primary outcome for at least the initial, the only results we have so far, the initial ones, we're going back into the field for 18-month results, is this combined anxiety and depression scale. Psychologists here can tell me whether it's Weaver or not. It had been used out there. We saw some validated papers on that. So basically think of it as really as a unidimensional, in a sense, combination of anxiety and depression. And so here's my one figure. So they're not, the sample size is small here. They're not quite balanced at baseline, unfortunately. Just the randomization is really small. We do, we put that in as a covariate in the regression analysis we do. And so we look at 5 weeks and we look at 3 months, and we do see a gap. So we see some improvement. So there's at least one setting here where the program management can seem to make a difference. Not a huge difference, but enough. It's valuable for these guys. And even though it's not professional counselors delivering it, it's marginally significant, not too much. Depends exactly on how you run the analysis. So happy to caveat that there.
Sorry, this is the ICT, right?
This is our CT, yes.
No, ICT, intention to.
Yeah, ICT. This is
all. So only 64% take it up.
Yeah.
It could be.
Yes, that's right. And so it depends what you think is the policy relevant version, right? They're both reasonable questions to ask. But yes, this is ICT. Yeah.
Just to clarify, if it's intention to treat, that's only if you have an outcome. Could you impute the outcome for those who don't have, if they drop out?
Oh, so yeah, so sorry, the take-up is just the take-up of whether they showed up to the sessions. Yeah. I don't know if I have a number here, but they just got $14,000 from the World Bank, so they answer our questions. So we go and talk to them. Yeah, so we don't have dropout in that sense. It's just, obviously it's a voluntary program, we're not forcing them to come to the program. So the attrition in that sense is quite low. Okay, so this is what I don't have the results on. So this was planned from the beginning to look at, so in some sense, large parts of the World Bank care about employment. One more slide, so that's it. Business performance. So we thought there would be less likely to see an impact of that right away, because that might take some time to sort of change the way of thinking and see different business performance. But look at some of these other outcomes. If people have strong opinions or suggestions around this, then let us know, because this is not set in stone yet, but we're going back fairly soon to do that. All right, so concluding this last slide and stepping back a little bit again to the broader view, this goes against what we heard earlier, so we can have some discussion about this, but I do think for scalability, at least for right now, and where there's a quantity, so when we were working in Liberia, there was 1 psychiatrist in the country of 3 million people. There were 0 psychologists in the country of 3 million people. So it's hard to get professionals to do it, as much as I would love to have them there. But I think adding technology is great. We added the WhatsApp groups here. I think some combination is fantastic. So let's come up and try more of those. Another thing I'll just throw out there is that relative poverty for some of these things, relative insecurity, relative exposure to conflict. We did actually, the one experiment we did in the Nigeria one is we either asked them first about exposure to conflict and then depression, or the other way around. We get different answers on the depression score depending on whether you prime them. It goes both ways. The people who were exposed to violence and are asked about that first report higher depression. The people who were not exposed to violence and get asked that first report lower depression. So they're sort of reminded that they weren't exposed to violence in a setting, a context where there was a lot of violence. Should we intervene on perceptions? If that is part of it. Should we sort of, is that a way to make people better off? And then finally, causality and mechanism, sort of this workshop is on, sort of, we have this poverty, we have cognition, we have mental health. You know, things go in all different directions among those. If we don't know for sure, this is, you know, I'm really throwing something out here. Should we start with the one that we care about directly and hope that it affects all the others? And that one is... So I would say mental health, if I had to say. I would say mental health is the one, because we directly care, I care about poverty because it affects people's welfare. So if I have something that can affect mental health, and I think that's going to get to the others, maybe start there. Thank you.